Thank you very much. I'm delighted to be here today, and I want to thank the Forum for the Planning Committee for inviting me here to speak. I'm going to diverge a fair amount from what Mark talked about, and I'm delighted to pick up where Warren left off. I'm going to talk a little bit about comparative effectiveness in cancer. And to start off, there's a well-known statistic, and I heard this morning it was 30 years, but the statistic that I've heard in implementation and science is that it's 17 years from bench to bedside. And that the three policy issues that I'm going to talk about today really are raising issues around what we can do to get evidence-based medicine into practice more rapidly. And I think that we face formidable challenges today with the rapid adoption of new technology. And some of these new technologies may actually prove to be very important for saving lives. Some of them may actually be equivalent and more costly. And worse yet, some may be more harmful than status quo. And comparative effectiveness research is going to be critical for helping us solve these issues. So what do we know right now? We know that newer is not necessarily better. That may be a hard lesson to learn from what we've heard this morning and all of the new advances in technology in the very basic omics, and I'm not going to talk at all about the omics today. We also know that evidence is very hard to communicate and is weighed differently by different people. And we also know that status quo does not sell nearly as well to competitive systems and providers or to patients as innovation. But most importantly, delays in getting answers for the public on the harms and benefits of different healthcare options is not helping. Everyone wants to know what works better and what improves outcomes, and outcomes may be viewed very differently by different people. I believe that comparative effectiveness research is going to be critical for accelerating evidence generation, and I hope that we can move towards the Goldilocks of healthcare, which is not too much and not too little. So I'm going to focus a little bit on that today, if I can. An underlying theme in this presentation is that researchers, and I am certainly one of them, need to do a better job of involving and integrating decision makers and patients into research. And we must help individuals in healthcare systems and providers understand the importance of being active and passive participants in research. And this is something that Warren spoke to and I think is really critical when we start talking about learning healthcare systems, which Peter's going to talk about later on. So with that, I'm going to start with, if I can move this, there we go, the three policy priorities that I want to talk about today. The first one is investing in data. The second one is developing and implementing multi-level incentives for systems, providers, and patients to participate in evidence-based development and the adoption of evidence. And the third one is to support fundamental shifts in academic milestones of success. I'm going to touch on each of these right now. So what is the problem? In terms of investing in data, the problem is that big data are everywhere. And I know that Warren said we talked a lot about that this morning, but that's very different big data than what I'm talking about. There are significant problems with big data in terms of timeliness, quality, validity, depth, breadth, and diversity, and each of these factors limit our ability to disseminate, translate, and implement research into practice. So I think that we have a very important fundamental need to increase our efficiency. And most critically in CER and cancer, we have important timeliness lags in data acquisition. And just a very small example, simple example of this is that there's about a 2-year lag in cancer registries and death tapes, which prohibit the ability to look at comparative effectiveness research and outcomes in a rapid manner. So that's just a very simple point that I want to make. Funding cycles, we all know, have a significant way to go in terms of improving our efficiency. I think we're starting to move a little bit towards that with PCORI and more rapid funding cycles, but I think we have a long way to go. So the priority areas that I want to touch on, and I was really actually delighted to see some of these mentioned in the briefing booklets. Cancer subtype information, we've learned a lot about that this morning, that lung cancer, there was a picture on the right of, or left of lung cancer and a picture on the right of what we now know about lung cancer. This is very true in terms of what we have for big data and registries from cancer information. The subtype information is just not there to be able to do the type of research that we need to be doing. Patient-reported experience and outcomes. Mark just touched on this, quality infrastructure. and it was touched upon also in the briefing booklet, that we really need to be looking at patient-reported experience and outcomes for comparative effectiveness research, but also in general that the outcomes differ for different people in the way that we want to see the information collected. Treatment data is very limited in terms of what we have. Certainly in big data, it's very limited. And in our cancer registries, it's also very limited. And diversity of our populations that we're studying. I also include here comorbidity and life expectancy and end-of-life data, which are also in great need of additional data. The second issue I want to talk about is the implementation of multi-level incentives for all sorts of people to participate in research. And I think that the problem is, and this was said a bit earlier, is that there aren't a lot of incentives for people, particularly when you're talking about healthcare systems that are hemorrhaging money. They have a very different timeline than our research's ability to provide. They need to make best guess decisions, and there's also huge competitions to be early adopters of new technology. Providers are too busy, patients are afraid of how their healthcare information will be used and shared, and federal protections may not always be acting to serve to protect the patients, and that has been touched on as well. So what do I think about some of the solutions? Mark just touched on this. I think that research support for evidence generation through things like coverage with evidence development is going to be critical for the type of things that we were talking about this morning, as well as new technologies and new treatments. I think that this would provide information on testing innovations while simultaneously collecting evidence on harms and benefits, and provide opportunities for new ways of collecting long-term outcomes. I think we have a long way to go to build trust, to encourage active and passive participation in research, and this is going to be critical because we need patients to be able to provide us with information, and providers and healthcare systems, in order for us to generate information that they actually want as end users. Federal protections for data. I was really, it was not until yesterday on the plane that I learned that the next forum meeting that's going to be in February here will talk about the contemporary issues in human subjects protections. And I think that that is going to be absolutely critical for doing the type of research in comparative effectiveness such as pragmatic trials. And this was also touched on this morning in spades, I think. The third topic, the problem really is that a lot of, although this is changing in some institutions, a lot of organizations and academic institutions do not have milestones that are well aligned with translating research into practice. And I think that it's a very big problem for the research community to partner with the types of people that we need to partner with in order to advance science more rapidly. So what I mean by this and some solutions is really to expand support for true multidisciplinary collaborations. And I really mean something very differently, and it has also been touched on today. I think that other fields have been successful, like Amazon. They know how to provide information on what people's personal experience are, the products, and they allow people to make their own choices around value and their own decisions. I think that we have a fair amount to go in terms of health sciences research. Stakeholder engagement is something that is much harder for academics to measure. It's time-consuming and not something that we're trained very well in. Null results. I can't emphasize enough that I think one of the things that we have in science is redundancy, because null results are not treated as equally important to new discovery, despite the fact that null results are new discovery. And I think that we could be quicker in terms of our scientific contributions if we felt that way and treated that way. And two more things, academic credit for sharing, and this is simply things as simple as sharing algorithms, sharing data, sharing tissue, all of these types of things that were touched on this morning. And finally, the success for dissemination and implementation, a scientific publication is not enough to propel our field forward and engage patients. So these are the three policy areas that I wanted to touch on this morning, and I think that I just wanted to summarize to say that for us to be more relevant, we need to be more rapid, and we need to be more generalizable to subgroups of individuals. Even if all of these policies were put into place, there would still be a lot of unanswered questions with comparative effectiveness research and uncertainty. But certainly addressing some of these policies might help move the field of comparative effectiveness forward. Thank you.
Great. Thank you very much, Ed. And we'll pause for questions at the end. So we'll look forward to gathering those questions and having a more thorough discussion. So next will be Lowell Schnipper, who will speak to us on the affordability of cancer care. Lowell is the clinical director at the Beth Israel Medical Center and chief hematology and oncology.